Today, I am going to be talking to all of you of one of my favorite topics, um, stress and stress related to risk, right? So today, like the idea is that we're going to be talking about how relative risk can be. And we are also going to talk about the long-term impact of stress on mental health. As Megan said, like my name is Cecilia, and I have this company called Trans Equity, and I am so happy to have the opportunity to work with all of you at the University of Rochester. So let's just jump into it, right? I want I want to give you all a little bit of an idea of what is a historical understanding of risk. So let's talk about it, right? For way too long, from my point of view, risk has been viewed as an absolute and objective issue, right? Some activities are risky and some are not, according to a magic universal metric, right? We have all been looking at risk and understanding risk in a very binary way where things are risky or are not. And all of this is measured with some kind of universal metric, right? Historically, risk behaviors that could be, for example, drug use, non-normative sexual behavior, or gambling, for example, have been portrayed as moralistic issues. For that, individuals who engage with them are lacking self-control or otherwise are viewed as deviant or morally suspect. Under these views, these behaviors should be shamed or criminalized, right? In order to discourage people from engaging with them. For much of the 20th century, this is how people view other people who were trans, who were gay, or who otherwise somehow diverge from white, heterosexual, monogamous expectations. But in more recent years, these views have been updated and replaced with a form that is based on a more compassionate condescension, the views, the behavior as not originating from failure, but rather a disorder or a mental affliction. With this framework, people who, for example, use drugs or participate in the sex trade are not seen as immoral criminal anymore, but rather powerless victims of their circumstances who needs to be somehow rescued from it. However, this continues to have an absolute all or nothing view on these behaviors. You are either 100% sober or you're suffering from addiction. This perspective continues to deny individuals the autonomy or the agency over their own lives, and still is fundamentally rooted in a perspective that seeks to eliminate these behaviors based on a prescribed metric, right? So what I want to introduce to all of you today is the idea that risk is relative. The reality is the risk is different for everyone. What seems risky to you may not seem risky to me, right? Some people could, for example, never imagine living in New York City. I was one of them, right? When in the 90s, right? The thought of it just feels so scary and so risky to even consider it. And look at me, I live in New York now, right? And millions of people do that every day, right? So for them, it doesn't feel risky, it feels like their home. Likewise, for example, some people could never imagine doing heroin because the risk feels far too great, right? Similarity in a similar way, thousands of people use heroin every given day. In a more personal case, some people would think that injecting silicone in their bodies could be risky. But for me, as a trans woman, was something that I did many times, and it was really normal. Risk doesn't exist in a vacuum, right? It is deeply informed and shaped by our personal experiences. And also the intersecting aspects of our identity. This is one of the key problems with trying to enforce an absolute view of risk. In reality, that imagined objective measurement comes from a very specific place. And historically, that has meant that it's coming from what is deemed risky by wealthy people, white people, cisgender people, and heterosexual, all of them, men. Simply existing in a world, in this world, as a trans woman of color, is a risky behavior, right? Because of the overlapping layers of society's racism, misogyny, and transphobia living at the same time. And because of this, how I measure risk will be different from a person with more privilege will assess this kind of risk, right? So the so-called risky behaviors can be a part of someone leading a full life, right? If you look at me living my full life, that may look like a whole bunch of risky behaviors at the same time living together, right? You see it as that, I see it as a full life, right? They can also be a coping mechanism for getting through a difficult situation, right? There are millions of people worldwide who, for example, use drugs on a daily basis in order to function, right? To do their jobs, to show up in their relationships, and to feel safe and stable, right? Some of those people access those drugs through prescribed medications that are provided by doctors or pharmacists, right? Some of those people access those drugs through informal economies, friends sharing prescriptions, purchasing online or in the street. One of those groups is allowed to engage with these drugs without fear. without any fear of criminalization, and without any fear of stigma. And the other is not. Many people in very difficult, traumatic situations relied on risky coping mechanism to endure and move through that situation. For example, people enter into sex work for a variety of different reasons, right? On a spectrum of choice, circumstance, or coercion. What some may seem this as a risky choice may be one of few available options for someone who has no other way to earn money or to keep a roof under their head or to put food under the table or to take care of their children, right? This is, for example, why so many people in the sex trade are people who are marginalized and look out of traditional employment, like transgender people, transgender women, undocumented folks, people with disabilities, or people with chronic illness, right? Trying to prevent people from engaging in these behaviors because they're too risky is more about moralizing than is about actually trying to help the person in a difficult situation. So, what is the role of a provider in managing risk? What is your role as a provider in managing risk? We all want everyone to be safe and to be healthy and to live long, successful lives. I know all of you in this room today want that. And I have never met a provider, medical, mental health, case management, who do not want the same thing, right? We all want the same thing. We want our people to live safe and healthy and have long and successful lives, right? We all want that. I have worked with thousands of healthcare providers through many different trainings, conferences, and other collaborations. And I know that on the whole, most providers want their patients to be safe, right? This is when it gets tricky. Unfortunately, many times, these desires end up coming across as having to make decisions for our patients or clients. This perspective comes from an updated and paternalistic understanding of the role of a provider in relationship to their patients. It is a perspective that imagines that provider is the only expert in the room, right? And that they need to educate and correct their patients when they engage in risky behaviors. The reality is that while the provider is an expert of medicine or another field of the healthcare, right? Mental health or case management, right? The reality is that the individual is the expert on themselves and their own life experience. They are the only one who can make assessment of risk for themselves. They are the only one who can make an honest assessment of risk about their lives. They are the only one who can make an honest assessment of their behavior. So, instead of trying to force patients to make one choice over another one, it is more helpful, from my point of view, to take a harm reduction approach that empowers the individual to make choices that work best for them. These may look like, for example, providing educational materials and resources about the potential harms, as well as strategies that they can employ to reduce that harm. I remember, as a trans woman who was managing a clinic, and so many trans women were my clients, but they were also my sisters. They would come and they would talk to me about getting silicone, right? So I am pretty aware of the risk of getting silicone, right? But at the same time, I know how much silicone changed my body in a way that was positive for me, right? And at the same time, I know so many people for whom silicone end up being a life-threatening issue. So what is the best thing that I could do, right? Do I have to help them make a decision? Do I have to influence their decision? No. The best thing that I can do is to provide educational materials and resources about the harms the silicone brings, right? As well as strategies that they can employ to reduce the harm. It may look like, for example, connecting individuals to low barrier entry support programs that they can access if and when they want to do that, right? Or above all, it looks like having candid conversations about what the relationship with that behavior is and what the goals are and how you can best support them to reach these goals. One of the most useful examples for this is informed consent, right? Informed consent is a piece of information, right? A piece of educational piece where a patient gets to know everything about hormone replacement therapy, right? They can go to the medical provider and discuss some specific items that are of interest to them, right? Remember, every transmasculine person was like, oh, I really want to lose my hair, right? That was the most common one, right? So there you go, and then you have a conversation about that with the medical provider. And then you make an informed decision about studying or not. So this does not mean that you need to minimize or ignore the harm that can come from risky behaviors. I'm not asking you to ignore it. I'm not asking you to minimize it, but rather that you recognize that the individual is the primary agent on keeping themselves safe. When taking a harm reduction approach, it's always important to remember that you cannot expect someone to draw the same conclusions that you would based on the available information. You may think that based on the risk associated with a particular behavior, let it be drug use, let it be alcohol consumption, let it be sex work, let it be silicone injections, that you would never choose to do that once you knew how risky it was, right? This is where it's very important, it's vital to recall that risk is relative and risk is shaped by our own experiences and our own identities. Now, this is the moment in which we are going to try to connect stress as a consequence of structural inequity. As we have talked before, I have talked, risk is a relative phenomenon, right? Risk is totally relative. And we also mentioned that it's not the role of the provider to manage risk for their patients, but rather the role is to educate and support individuals in making choices that work best for them. And of course, take notes of everything. This is true on an individual level, and it's specifically from my perspective, the best way for providers to intervene and support their individual patients. However, I want us to zoom out a bit further and look at the conditions that create these uneven experiences of risk, right? What are the experiences? What are the conditions that create ideas of risk in an uneven way? What are the specifics that make risk different for you and for me and for Heather here interpreting, right? While it is true that risk is relative, the circumstances that produce our experience of risk are not arbitrary or they're not random, right? They are determined by structural inequalities that shape our experiences in the world. For so many people, navigating the world means navigating an ongoing reality of precarity. Let's think, what does this look like? For so many, this means struggling to make enough money to make ends meet, right? For others, this means dealing with being criminalized for survival and the possibility of incarceration over their heads consistently, or even deportation. For example, trans folks, specifically trans folks who engage in the sex trade, are often dealing with all these things alongside a very real risk of violence from their clients, violence from strangers, violence from our loved ones, or violence from the police, right? 47% of trans people are sexually assaulted in their timeline, in their lifetime. For example, 15 of Black trans women report being physically attacked in the past year because of who they are, because they are trans, right? And note that this number is likely to be even higher as trans people, and especially Black trans people, are very unlikely to go to the police, right? 46% report being uncomfortable with seeking police assistance. So this is just to say that this number of 15% of Black trans women being physically attacked is most likely, and I can assure you that it's much higher, and it's most likely to be higher due to the fact that trans people and Black people, and women, and specifically Black trans women altogether, right, are not likely to seek police assistance. So all these overlapping experiences of structural inequities result in significant increases to the amount of stress that folks have to endure, right? Over time, the stress levels become normalized as individuals becoming accustomed to it, which can often result in people no longer registering it as stress or anything out of the ordinary, right? What does that mean? That over time, we live with this kind of stress consistently, that we stop thinking of it as stress, right? I see it, for example, with legislations, right? The first time that we hear about some of the legislations that would make the life of trans people terrible, I felt very stressed about it, right? Nowadays, every time I look at the news and I see another piece of legislation in another state being going through or being drafted or being talked about, I have stopped thinking about that as a stressful matter because I got accustomed to it. I got used to it. But the reality is that this kind of stress accumulates in the body and has very serious health consequences. I'm talking to all of you right now with shingles in my face because of the stress that I endure. And I can tell you that most of this stress doesn't come from work. It doesn't come from family issues. It comes from the oppressive reality that I live with as a trans person, right? So what is the impact of stress on mental health? Let's focus on specifically how this impacts trans people of color, for example. According to a nationwide survey, the majority of all LGBTQ plus adults of color in the United States, face significant mental health challenges. These challenges are often made more severe by the intersecting experiences of transphobia and racism, right? That we face specifically as people of color or trans or gender nonconforming or non-binary people, right? These experiences of transphobia and racism begin in our youth years, in which nearly 1 in 10 trans youth are kicked out of their home due to their gender identity. A risk that is 83% higher for Black youth, right? This results in the majority of LGBTQ plus youth of color reporting feelings of anxiety, depression, hopelessness, or feeling worthless, right? While only 35% of these youth of color receive any kind or any form of emotional counseling, right? So I want you to think for a minute, what is the reality? What is the understanding of stress of an adult that experience anxiety, depression, hopelessness as a child, as a young person, when they become adults, right? It gets to the point where all those stressors are understood and read by the body and by the mind as normal, right? So all of these things result in adults, people of color who are transgender, or gender non-binary, or non-conforming, that at the same time face some kind of the greatest need for mental health, while being one of the most systematically unable to access high quality trans competent services, right? Black trans people face poverty at 4 times the rest of the general population, right? Which results in more than a quarter having no health insurance coverage, and nearly a half of them having to delay seeking any form of healthcare when they need it, due to the inability to afford it, right? So it is important to have these conversations about mental health and about structural inequalities together, right? We cannot separate them. We cannot separate mental health without talking about the structural inequalities. And when we talk about these structural inequalities, understanding the identity of these folks, the realities of these folks, the ideas of how they see and perceive risk, and how they made decisions coming from a precarious place. And although I'm not going to say that it's not providers who may have experienced the same realities, most likely mental health providers are going to have an understanding that is different when it comes to risk and making decisions around risky situations, right? So again, it is important that we have these conversations about mental health and about inequalities and about risky situations together, because otherwise it is easy for us to miss the grounding context that is driving these issues. So as long as these massive inequities in, for example, housing, healthcare, employment, family issues remain, and as long as the threat of criminalization and, for example, in my case, deportation remain, the stress that marginalized communities endure and live with, but particularly the stress that trans people, and specifically the stress of trans people of color, will continue to result in negative outcomes for our physical and for our mental health. And the relationship in between mental health and physical health is, I hope I don't have to remind you, so close, right? It will also continue to shape and ground their experiences of risk, right? The experience of risk of a person who is homeless is going to be shaped by their homelessness. The experiences of risk of a person who could not get a job for the last 2 years are going to be extremely shaped by their experience, right? The experiences of risk of a person who lives with a consistent threat of criminalization is going to be specifically crafted by their experience of criminalization, right? So our realities shape and ground our experiences of risk. And while it may sound as a contradiction, these problems must and should be handled in two divergent ways, in which providers engage with their patients around ideas of risk has to be individualized, right? And tailored to that person's experience, and tailored to their identity, and tailored to their specific goals, right? That means we cannot apply cookie cutter ideas of support to all our patients, right? We have to look at our patients in an individual way and weight their identity, who they are as a person, right? Who they are as their experiences, right? Who they are as their goals, right? And then look at risk from their perspective and not ours. The way in which we engage with the negative health outcomes for long-term stress, for example, must be a broader systemic level. These changes strive to engage with the structural inequities that drive our stress. And as I mentioned before, we live in a very specific moment for trans people. We face unprecedented attacks on our very own existence. And that creates a reality of stress in which we make decisions with a different specific measurement of risk. My partner asked me a couple of years ago, how come, you don't have any plans for the future? And I told him, I never seen myself with the future. The majority of trans people that I know nowadays look at their reality being shaped by all these laws, by all these terrible narratives, in a way that creates a very specific precarity for their lives, right? So people who live in precarious realities with precarious futures are going to make decisions with an idea of risk that is shaped by it, that is shaped by that consistent stress that, as we mentioned before, at a certain specific moment, stop feeling like stress and is the reality of our lives, right? This moment, 455 anti-trans laws have been processed across 42 states in this country, and 9 of them already passed. Both are record heights for 2023, with the year just beginning, right? The sad truth is that between when I started drafting this speech and now, both of those numbers are most likely to be much higher. Online campaigns of harassment and hate are being directed at trans people at the hospital that serve us, like you all, as drag performers. Many hospitals and clinics that I work with have had to remove information from their website due to people making direct threats to their doctor, nurses, and healthcare professionals and trans people. It is a gang of fascists that have been showing up to protest outside of queer events, of libraries with drag performers who are reading to kids, including right here in Queens, where members of the Proud Boys and other far-right individuals have been harassing people in public, in a public library in Jackson Heights, right? So all of these creates a very precarious situation for so many trans people, right? And it creates a very specific reality in which we live with consistent stress. And because we live with consistent stress, we make decisions in a very specific ways. And most of those decisions that we make involve ideas of risk that are going to be specific to us being who we are. And the idea of risk is most likely going to be different from the ideas of risk of the mental health providers. And all I'm asking is that as mental health providers, as healthcare providers, we start making an effort to look at decision-making from trans people, and specifically from trans people of color, understanding that they live with consistent stress that at a certain moment will stop being perceived as stress because it's normal, and with ideas of risk that are based on their own identity and their own realities. And that we make an effort to understand those realities, to understand those decisions, to understand the stress, and we support them without adding our understanding of their lives. So that's all that I have for you, and I believe that we will have time for questions, right? Thank you for paying attention to me. Thank you. I really appreciate you all. That didn't feel like I had like a sense of ending, right? Because I started talking about things from the heart. I always like to do and deviate from my speeches.
Cecilia, I just wanted to let you know that the first person posted, Cecilia preach, you are amazing, you know, and speak the truth. So for those of you on Zoom, please send us in the QA. And then for those of you present, is there anybody that has a question?
Thank you all. This is like really nice, and I'm super I'm super like interested on this topic, right? As a trans person, as a sex worker, as an undocumented person, I have always made decisions that were seen by medical providers and mental health providers as risky, and most of the times I've been tried to be shut down from making those decisions in a very paternalistic way, and that has created a certain scar in my relationship with mental health providers. We have Ian here. I'm an adult since, but
do you want me to read his question aloud?
Yes, do it.
Okay, all right. You make compelling points about how individual patients are probably best judges of whether the costs and benefits of a given treatment are worth it in their own lives. Among adults, this seems like a straightforward and good idea. But we also know that children and adolescents are generally poor judges of long-term risk based on simply on the fact that their brains are still developing. How do we balance the need to respect the lived experiences and the choices of our children and adolescent patients without putting them in a position of making long-term decisions that they might not be ready for?
Thank you, Ian. Thank you so much for this question. And I truly appreciate this point of view. As a person who started my transition as when I was 17 years old, I started my medical transition. I started doing hormones, right? I didn't do it with any support from a medical provider or from a mental health provider or family or anything. Nowadays, these decisions are not made just by the young person. They are made in a conjunction of family members, medical providers, mental health providers. So these decisions are not a decision that are made just like a young person who is like, oh, I'm gonna start hormones. This is what I'm gonna do that, right? And then it's natural to think of like maybe they'll change their mind, right? So what I say is like the most important thing that I think of around this issue, and thank you for bringing it up, is kind of like and I know it's hard to ask for patience from young folks, right? They want everything right now. No, now, yesterday, last week, right? But to work on processing the information, on waiting on the risk, and the benefits, and also with the parents or family members or whoever is caring for them. To make decisions that are informed, right? And we put all of that out there and we help them make that decision. I have to say also, the most of the decisions that youth make nowadays do not have long-term consequences. And most of those decisions are reversible, right? And in a very easy way, right? We don't do vaginoplasties on 10 years old, right? The most likely, around 12 or 13, you may try to do this blockers, right? And that's something that can be reversed, right? And around 15 or 16, you may start with hormones. And those changes are very easy to reverse if the person is change their mind. And also, I have to say, I have met very little number of people who change their minds. Thank you, Ian. Thank you so much for bringing this up.
Thank you. There is another question here from Kristen. Are there any specific suggestions or requests you have for health and human service providers to better serve their trans and gender nonconforming patients and clients?
Yes, thank you, Kristen. Thank you so much. I would say when I talk about stress, right? You may find trans people who have been living with stressful situations consistently for years, right? So they may come to you presenting all happy and not showing any of that stress, because those are things that we do, right? It took me years of therapy to unearth issues like sexual assault and sexual violence, right? Because I was all trying to portray this happy idea of myself, because I lived with that kind of abuse throughout my whole life, right? So I would say patience. We are not, the process of healing is going to take much longer than you think, and it's going to take much longer than you want to, right? So we all have goals. I don't know you, Kristen, but I'm a person who is just kind of like results oriented, right? Oh, we're going to change your name, and we're going to start using hormones, and we're going to just get rid of all your trauma, and in 2 years you will be great, right? The reality is that processes take much longer, and it's okay, right? It's okay. In that case, your role as a mental health provider is going to be to manage expectations, right? So at the same time that you're working with trauma, you're working with the stress that they live with, you help them go through decision making with the least amount of risk that you can. At the same time, you pace yourself and you help this person understand that these processes are going to be long processes, right? And manage expectations in a way that is proactively trying to decrease stress when those results don't happen when they expect them, right? So I hope I didn't go. I know I go all over when somebody asks me something, but thank you, Kristen. Thank you.
I think these answers are extremely helpful. We have another question and a compliment. Thank you, Cecilia. I lead a research lab studying strategies to reduce loneliness. Do you have any ideas to share on what has helped you or others in the trans community tackle loneliness and feel a strong sense of belonging? Thank you, Kim.
Yes, Kim. I am my life changed dramatically when I went to a group. It was at the LGBT center, and I cannot explain. I can feel it right now, opening the door of a support group room and finding about 60 trans women. Some of them were sitting on the floor because it was not enough space, all together. And sometimes we ended up talking shit and very problematic things, right? But it didn't matter. It was a group of people together. So I say, like, nowadays we have methods to create these spaces at distance, right? Which is so important for people in rural New York, right? So support groups, right? I have a meeting with the Office of Mental Health next week to talk about creating peer support counseling, right? My life changed when I got counseling, and my counseling didn't come from a mental health provider. It came from a peer, right? Peer support is so important. It's so important. So sometimes, as a mental health provider, yes, you can bring a lot to the table, right? But sometimes another person living their same experience may bring so much more. So be open to creating connections to eliminate some of that loneliness.
Thank you. Gabby asked, with your experience with our specific institution, what do you see changes specifically needed to improve the care of our trans patients?
I would say, well, you all know that I'm a huge supporter of informed consent, and I will continue, matching that on everybody, right? Uh, um, eh, Creating an idea of informed consent really makes people being able uh, to create a reality for themselves that is on their own, right? I think, like, implementing informed consent in a much bigger form, it could be really important. I think we have to continue educating everybody. These conversations that we're having now, we should be having in person, in a workshop where we can talk face to face, right? This was going to happen, but unfortunately, it couldn't happen. But we should be doing it with all departments, right? We should be having these workshops, right? We should be having all of these, and listening to people, listening to trans people about what they want and what they need. It will be really, really important.
Thank you. All right. Do we have time for one more question, or are we out of time? I think we have about 1 minute left.
Yes, I think Lisbeth says what a student can get involved with your organization and research. Are there any ways students can get involved with your organization? Yeah, Lisbeth, ask Megan for my email and send me an email, and we can see how we can collaborate. I love students. Good students create good professionals for the future. So.
Right?
Thank you, folks. Thank you, everybody, and thank you, Megan. Thank you, Megan, for introducing me and for facilitating this space and for all the work that you have been doing for the trans community at the institution. We're starting seeing the fruits of all your work, and I just can think about all the things that you will continue creating to make the experience of trans people at the University of Rochester better, more fruitful, and more impactful and intentional. So thank you, Megan. Thank you to the University of Rochester for having me and for believing in me and in my experience and my expertise. And thank you to all of you for being here. And thank you. Enjoy the rest of the day.
Thank you. If folks have any additional questions, by all means, feel free to reach out to me by email. I do have the role of Clinical Director of Trans Patient Experience, so I can help get you connected to local resources and support. Thank you.
All right, you all.
All right, Cecilia, thank you.